Hi, my name is Luigi Adamo. I work in cardiac immunology at Johns Hopkins University, and I had the privilege of moderating a session on cardiac immunology. And we are here with one of the speakers, with Dr. Prabhu. Dr. Prabhu, congratulations on your work, really an impressive amount of work. Why don't you tell us a little bit about what you discussed today?
First of all, it was an honor to present my work at the session. We presented our recent study on the links, the inner organ links between the spleen and the heart after a myocardial infarction. And the gist of the study is that there are specialized macrophages in the spleen that traffic in the monocyte population in the blood to the heart, and they then play an active role in expanding the macrophage population in the heart and contributing to healing the heart after the infarction. We are very excited about that work. We think it offers a new avenue, a new way to look at the immune cell communication between the spleen and the heart, and also affords a new therapeutic approach to modulate the spleen to heal the heart.
So we heard that during the same session there was another presentation about macrophages. Dr. Eppelman told us about how the macrophages interact with the cardiomyocytes. There is so much interest in macrophages, and you picked really this, I would say, new population within the resident macrophages. Can you summarize for our audience, what do you think that makes this population special?
Yeah, I think it's special because it performs a special role in the spleen of bridging that innate immune system, that those cells that are macrophages are continually screening the blood for antigens, for dead cells, and then talks to the adaptive immune system, the B cells and T cells that are in the spleen, in a way that is a sensor for the rest of the body in terms of either infection or injury. I think that this, what we've shown is that the injury in the heart activates this system such that it draws some of these macrophages away from the spleen into the heart, and where they can do their reparative functions. And I think that's what's new about this paper.
Yeah, there were a few things that I found really striking. First of all, the amount of work, that was really a major undertaking. And then also, we are used to think about the resident macrophages, CCR2 negative, as resident macrophages, reparative macrophages. These are CCR2 negative, but they're not so resident. They're coming from the spleen, and you went really long way to show in a definitive way that they come from the spleen. Can you tell us a little bit? I think, as a more junior scientist, I'm always interested in the struggle to get the paper published. Do you want to tell us a little bit about your journey? It's really an amazing amount of work that you put in there.
Well, it's funny you should say that about the current paradigms. We started this work 10 years ago. During that period of time, when we started, there was no definitive classification of resident versus infiltrating cells. So that came about during the time we were working on this. So we had to continually adapt what we were seeing. In fact, if we had published this 10 years ago, there would have been no issue with these are resident cells versus infiltrating cells. They were just macrophages. But it turns out that if we had started with that paradigm of resident versus infiltrating cells, we may have never pursued it, because we would have said, well, these are resident cells, they're not moving anywhere. But we saw what we saw, and we had to explain it in the context of newly developing science throughout that time. That is probably why it took a long time to get there.
And I think also tell us about the pace of science. Good science takes time. You mentioned the connection with your prior work. When I introduced as the father of the cardiosplenic axis. So in your first paper in Circulation, the adoptive transfer of splenocytes was causing adverse cardiac remodeling. Now, the adoptive transfer, or the communication between the spleen and the heart through this macrophage instead, is protective. Now, clearly, a lot of times, the immune system is more complex than just bad and good. But why? Can you comment a little bit about that, the two sides of?
Yeah, I actually think that's a very important point of this paper. The spleen is a healing organ with your first infarction. The spleen is responsible actually for healing many things. We don't have that data. We didn't show that data today. But if you do a wound anywhere else, so a tail wound, if you don't have a spleen, that wound heals much more slowly. If you have heart failure, though, the entire landscape changes. The healing part of the spleen is changed. It becomes an inflammatory organ. That inflammatory organ is not as effective at wound healing. And that might be one reason why people with multiple infarctions, perhaps, don't have as much of a recuperative potential when their systemic immune system is also altered. So I think that's an important point, and I think We need to understand that better.
You characterize these macrophages really extensively in the heart. They come to the spleen. Is just a communication between the spleen and the heart, or they go also to other organs? You mentioned the skin. Where have you looked at?
Well, we've really limited ourselves to looking at the transit between the spleen and the heart. We have not looked at possibly in the kidney, possibly in the lung. We haven't looked at any of those, but I would imagine that if they're going to the heart, they're capable of going elsewhere, and it would really depend on whether that organ is injured or in distress, and they need these cells in order to help heal.
There is some data from humans without spleens that actually, as you probably know, I study also the cardiosplenic axis, and it's hard. So because people without the spleen, they do worse actually after a heart attack. So your data might explain it. From a translational point of view, we don't think about removing spleens from patients, and the splenectomized patients are very few. You mentioned, I think for good reason, that you're excited about this finding. What do you see as the next step? As a physician scientist, how do you bring this to patients?
Well, there's two things. I think number one is on the discovery side. Really excited to see your work on B cells and how they may be important. But there are multiple immune cell populations in the spleen that are unique because this is a unique tissue. And we need to understand what is the communication, how do they link with each other, how do they link with other organs such as the heart, how do they impact both myocardial infarction and heart failure. But the second side is therapeutic. Our current therapeutics for immunomodulation are really geared towards systemic changes or perhaps localizing changes to the heart, for example. Is that really necessary? Can we then not modulate remote populations, remote immune cell populations, such as in the spleen, such as in the bone marrow? They're much easier to deliver cargo because it's a sinusoidal organ. So you can do nanotherapeutics without having to penetrate tissue. You can go to immune cells itself in the spleen. If then they traffic to the heart, that effect is carried with them. So I think it offers a new avenue for therapeutics that we need to explore.
It's fascinating. Also, you close your presentation with the data on humans. How data in humans is always tough. Also, these are the humans after a heart attack or after a PCI. Can you tell us a little bit more about this human data? And it was just the end of the presentation, but I think it's really the one that connects us to the translation.
I think it was fortuitous. We were trying to expand our work and understand the immune profiles in the blood in the human population. We had a cohort of patients that granted their permission to analyze their blood acutely after a ST elevation myocardial infarction. So we had a biobank of about 50, 60 samples. And the human studies are always important in the fact that the controls have to be very accurate because there are multiple comorbidities that can confound the data that you're measuring in the disease of interest. So we were lucky enough to also have a large population of patients undergoing elective percutaneous coronary intervention, or PCI, who had very similar risk factors to those patients undergoing myocardial infarction. So we were able to do a fairly precise adjusted comparison. And as you saw, we found these macrophage-like monocytes in the blood of humans as well. And we think they're probably important in that scenario too.
Let's say from the peak of your expertise and of your experience and building on the work that you have done right now, do you want to tell us, Spain, for our colleagues who are listening, where do you think these studies are going to go into patients? What is the path forward?
Yeah, no, first of all, I echo your points. I think the link between cardiology and immunology is exciting. It's never been as robust as it is now. And I think it's leading to a new understanding of the way we view cardiac disease, especially heart failure, especially myocardial infarction, but other diseases, atherosclerosis, hypertension, and so forth. If I had to guess, I think we're going to capitalize on these new discoveries and I think enter a new era of immunomodulatory therapy, especially for disease like heart failure, especially for myocardial infarction. The analogy might be with oncology, and oncology has seen an explosion of immunomodulatory and biological therapeutics over the last 15 years. And they did that because they understood basic mechanisms as well as the interaction between the immune system and tumor cells. We transpose that to the heart and understand the interactions between the immune system and the heart. We potentially could do the same, and I think that's what will happen in the next 10 years.
So thank you very much for leading the way. Thank you to the American Heart Association for inviting us and for organizing this exciting session on inflammation and the heart.
Thank you very much, Luigi.
Thank you.